Raise up for me, please, sir. Okay, so with Hujan, I'm gonna start with demonstrating the inferior glide of the clavicle on the sternum. So the medial head of the clavicle, I'm gonna be mobilizing inferiorly. I'm gonna be assessing it. So I'm gonna assess it. I'm gonna assess both sides. I'm gonna start with the right side, because it's right side, I'm just gonna say it's his non-involved side, okay? Now, what I want to do, see I have my tower roll here. Why do I have this tower roll? Good job, Andrew. Place him into the loose pack position. So you want to remember when you're assessing any of the 4 joints making up the shoulder joint complex with the patient supine, you want to make sure that you place your tower roll under the arm. I got it? So this is great. So his arm in the loose pack position, and he's abducted slightly. So just relax. Abducted slightly. Relax your hands right there. So good. So got him abducted slightly, about 55 degrees of coronal abduction. And so great. And he's not extended at the glenohumeral joint. So what I want to do now, since I am assessing the right side, I'm going to be on his left side, okay? And my right hand, my right thumb, the thumb of my thumb, so I feel his joint line. So I feel where his clavicle articulates with his sternum. You feel that, Pujan? I'm gonna move my hand slightly to the right, my thumb slightly to the right. And so now I have my thumb on the superior aspect of the medial aspect of the clavicle. I'm gonna take, this thumb is gonna serve as my dummy thumb. I'm gonna actually do the mobilization with my left thumb. And now my mobilization is gonna be inferior and away from the midline. So basically towards his left hip is gonna be my mobilization force. Come in. All right. And now I'm applying my force. At the sternoclavicular joint, I don't expect a whole lot of motion, but I want to get a feel for what I do sense. Remember, this is his non-involved side, all right? So I got my assessment of that side, and I'm gonna come and assess this side. So now what I want to do, put this side in a loose pack position. And now I'm gonna switch sides. Why am I switching sides? I gotta be on the opposite side because I want my force at an inferior diagonal manner, Okay, so I'm gonna come right here. So now, I can feel his joint line very good. You feel my thumb in between your joint line? Sure. So I'm in between the joint line of the sternum and his clavicle. So I move my hand. Okay. So I'm going to move my dummy thumb slightly to the left. I'm going to come right here, and I'm going to apply my force. And my force is going in this direction. This is my line of force. So he came in, right? And I'm sensing through my hands the amount of resistance that I feel and how far he can go. And I'm also paying attention to the motion. Is it smooth? Do I feel an abrupt stop? Do I feel any jerky motion, like aberrant motion? No, I did not. Both sides were very smooth. Both sides got to the end, which was a normal firm end feel of the joint capsule. Both sides translated about the same, so they were symmetrical, which would be normal. Although this was his involved extremity, right, involved shoulder, I assessed this one first, but at the sternoclavicular joint, I did not feel a significant difference mobility-wise and quality-wise with the inferior glide of the medial aspect of the clavicle on the manubrium of the sternum, okay? So on a Paris scale, what would I grade his involved side, a 3, normal, okay? Because that's what I sense. I can only go off of what I sense. You know, I'm not making up something. I'm just going off what I feel, okay? Now, the thing about assessing accessory motions, it could be subjective, objective, just like manual muscle testing, right? Meaning it could be different from patient to patient. Therapist to therapist. Could be different from therapist to therapist. So every therapist may not feel or sense the same thing. That's the only thing about this. Like manual muscle testing, Dr. McClure's manual muscle testing of somebody's middle deltoid and supraspinatus grade may not be the same as mine because I may be stronger than her, you see. So it may not be the same grade. That's why I always call it subjective, objective. And I consider assessing of accessory motion subjective, objective as well. But when someone truly has a limitation or pathology, there should be some inter-rater reliability. If it's truly significant something there should be some inter-rater reliability, okay? All right, so that's the inferior glide. So this is the side that I'm treating, right, or assessing. I'm placing my dummy thumb. So this right here, you see this right here? This is his joint line. Put your thumb there and feel it. Let me know.
It's going away. That makes sense.
Right there.
Okay.
You feel it?
Mm-hmm.
That's where his clavicle articulates with his manubrium. You should be able to palpate that. So we have to know how to use our hands for palpating. All right, so it's locating the joint line. So now I drop off of that joint line. So now I know that the joint line is not blocked in any way. And so this is my dummy thumb, and I'm taking my mobilizing thumb, and my mobilizing thumb force is going in an inferior diagonal lateral aspect. Knowing that someone has restrictions there, they typically wince. They have any type of pain. So the other side, coming right here, always make sure you got your patient in a loose pack position. Coming right here. Now, if I come right here, I feel his joint line. I'm dropping off of that. Okay.
Are you putting your other thumb on top of the other one?
Yes.
Okay.
So this is a dummy thumb. This is my dummy thumb. I'm just placing it right there. And this is my mobilizing thumb. And I'm mobilizing with my mobilizing thumb. My dummy thumb is just there. Okay. And so again, my grade is involved SC joint with the inferior glide was a grade 3 compared to the non-involved extremity. Because remember I said, how do you determine your grade? You have to assess the non-involved extremity. All right. And so the inferior glide of the clavicle, that was a component motion necessary for overhead mobility. So coronal abduction, flexion, any type of overhead mobility. An inferior glide of the sternum, of the clavicle on the sternum has to occur, okay, in order to achieve that full range of motion. The next one we're going to do is a posterior glide of the clavicular head. And so the posterior glide is a component motion that is necessary for horizontal abduction. Now, this is fascinating because now wet surface, so with the inferior glide, we had the convex portion of the medial end of the clavicle moving on the concave portion of the manubrium. But now it's going to switch because it's a saddle joint just like the CMC. So now it's going to switch. Now we're going to have the concave portion moving on the convex portion, the concave portion of the clavicle moving on the convex portion of the manubrium. So now with horizontal abduction, who knows what horizontal abduction looks like? Horizontal what? Abduction. So if I come right here, and come right here. This is horizontal abduction away from the midline, all right? Horizontal abduction away from the midline. This is horizontal adduction, okay? So now I'm gonna assess the component motion required for horizontal abduction. Come right here. Screw over just a little bit for me, Pujan. Again, the right side is the non-involved side. So now I'm gonna come right here and position myself on the opposite side. I've already located his joint line. I can use this thumb right here. Joint line, there we go. And now my thumb is on the anterior aspect of the medial aspect of the clavicle. Okay, is on the anterior aspect. And now I'm gonna mobilize posteriorly, okay? So the medial end of the clavicle moves or glides posteriorly with shoulder joint complex horizontal abduction. Does that make sense? So I can use this thumb, or I can come in and use my dummy thumb and make sure my force is going posterior, okay? Now, there was a non-involved side. That felt good. It was smooth. It wasn't aberrant. We were able to get to the end range. It had a normal, firm end range.
Are we going to be counted off if we don't use a dummy thumb? Or if we do?
With this one, you won't. With the other technique, you do want to use a dummy thumb with the inferior. So with this one, you won't. I just say you can do it either or with this one. So again, I want to locate the joint line, fall right off of that. And now my force is going to be a posterior force. So again, I'm assessing for the quality of the motion, right? So the quality is smooth. It's a smooth motion. So no jerky, no aberrant motion. We're able to get to the end range of that component motion, which was a normal firm joint capsule end field. What else? So in this case, again, it'll be a grade 3 normal when in comparison to this side, the non-involved side. Okay, so now I'm just moving from medial to lateral, okay? And so now we're gonna go over some joint plate assessments. So we got joint plate of the acromioclavicular joint. So now I'm moving the lateral end. I'm gonna be mobilizing the lateral head of the clavicle on the acromion, okay? And so, but this is considered joint plate motions necessary for all classical movements. So typically joint plate motions are necessary for all movements and benefit all movements, okay? So the first joint plate motion at the acromion that we're gonna be looking at is the superior glide, posterior superior glide of the clavicle on the acromion. So basically, I got him in a loose pack position, right? So his shoulder joint complex is about 55 degrees of coronal abduction. His arm is supported on a pillow so that it's not extended. And so I'm gonna come right here and just locate the joint line. So boom, I got where his acromion articulates with the clavicle. So I come in and I'm just gonna grab, I'm gonna actually grab the clavicle like so, like a pencil grip. And so what my first movement is superior and posterior. So I'm moving the clavicle in a superior and posterior manner simultaneously, okay? And I'm getting a feel for that. So I'm looking at my patient's response as well, okay? Okay, so I got a good feel for that. So in his case, in my patient's case, it was smooth. He didn't give me any kickback, meaning any jerky type of motion with that. I was able to get to the end. So I'm able to get to the end range, and I should feel on normal firm end feel with this due to capsule tightness. And also ligamentous, acromioclavicular ligament should tighten as well. with this. And so now I'm gonna go and assess the other side. And this is the posterior superior glide. Which end of the clavicle am I mobilizing?
The lateral.
Yep, the lateral end. All right. Okay. So boom, I got my articulated surface joint line. I'm coming off of it. And so now again, going superior and posterior. Now I'm gonna have to go back and feel the other side because this is fascinating. Then I'm gonna ask my patient something. Because your patients can give you feedback too. I saw him kind of wincing on that one. You saw him? Did you see him? Okay, I'm ready now to make a clinical impression, right? Or to give my findings. So, both sides were smooth. Both sides did not present with any aberrant or jerking movement. Both sides did not present with an abrupt stop. However, I was able to go further on this side. I felt like I was able to get more mobility with the posterior superior movement of the lateral end of the clavicle on this side. So therefore, my grade would be a slight hypomobility on the right side compared to the left. So he will receive a grade 2. That's basically what I felt. So I'm just verbalizing what I felt. How did it feel to you?
Yeah, I feel like you could move this one on one.
See, sometimes the patient will tell you. They will tell you which side they felt like could move more. So I'm going back to, actually, this side over here was greatest restricted. Yeah, so I'm gonna consider this his non-involved side. Okay? So, I'm gonna come here. I already know my hand placement. So now my force is gonna be anterior and inferior. So a simultaneous anterior, and I'm doing that with my index. I'm mobilizing with my index and middle finger. So my second and third phalanxes. So I'm getting a feel. So anterior, and simultaneously inferior force. Okay. Well, don't be afraid now. Don't be afraid to get in here. See how I'm in here? I'm on it. I'm gonna mobilize this. This is about to move. Don't be afraid. I can tell you right now, I don't even have to go to the other side. Less mobility. So he has slight, well, actually with this one, considerable hypermobility. So that I would consider this a grade 1 compared to this extremity. So you see how I'm determining that hypomobility. I couldn't get this one to go as far as I got with this one, with the anterior inferior glide. So when there's marked differences, it's just gonna jump out to you. Sometimes little subtle differences may not jump out to you as much, but if it's marked, it's gonna stand out when you do the assessment of these. Okay. So we can come right here. So good. Now, the first technique is the inferior glide of the humeral head without stabilizing the scapula. So in this instance, the scapula is not stabilized. Okay, I got different ways I can do that. I can just come right here and perform my inferior glide by using my body weight. So I'm not pulling with my arms. I'm just leaning back with my body weight and assessing how it moves. And you can actually see it. Can y'all see that? So you can actually see that inferior glide occur. And so I'm just gently leaning with my body weight. So now, look, this is very smooth. Do y'all see the smoothness in this? You can see it. So you can see nothing, that you can see that there's no abrupt stop. You can see that she makes it to the end range. All right. This is what I would consider a normal, firm infield, right? Because I'm at the end, okay? Due to joint capsule tightness and ligamentous tightness, all right? And so no problems with that, all right? Now I'm gonna see if the other side feels the same. So that was her non-involved side that I did first. Coming right here. And this is without the scapula stabilized. And you can visually look as well. So I'm able to get to the end. And so it's smooth. You see that? So I don't feel any jerkiness. I'm able to go. I'm just able to lean right on into it. And so what would I grade her after comparing both of those? 3 normal. Okay. After comparing the non-involved and the involved side with an inferior glide without stabilization. Okay. So now we're gonna go. Now there are different ways you can do it. Go back to that one, Dr. McClure. So again, this will be done in sitting as well. I rarely do this in sitting, but you can do it in sitting with imparting the force through the superior aspect of the humerus. Okay, so you can do it that way. So I rarely do it that way as well, and you could do it that way from supine as well, like so. Come on the lateral aspect of the humerus and gliding down like that. You see that? And this is without stabilization of the scapula. All right. I could use the wedge. Lift up. See how I'm placing this wedge on the scapula? Go ahead and relax. The wedge helps to stabilize the scapula, and it also helps to put it in a loose pack position. I come right here like so. Now the scapula is not going to move anywhere because it's into that wedge. And now I come right here and block. So right here, y'all may want to come around and see this. Well, I'll show you on that side too. So the dorsal aspect of my hand is going to come right here and block the lateral border of the scapula. Do y'all see that? So the dorsal aspect of my hand is blocking the lateral border of the scapula. Now I can come here, and now I can either come. So there we go. So I can perform my inferior glide by pulling the my force pulling towards my body from her arm, distal aspect of her arm. Or I can come here like so and put her 90 degrees of flexion and come right here and pull from the proximal aspect of her forearm and perform the inferior glide.
Trying to relax on your side.
So yeah, I got the same thing as without stabilization. So good. So she would be graded normal as my clinical impression. So again, I'm verbalizing that the motion was smooth. I'm verbalizing that I felt a normal, firm infield. It could be due to capsule tightening or ligamentous tightening, making it a normal, firm infield. And again, no aberrant, no jerky motion And then that's pretty much all you got to verbalize when you assess the accessory motion. All right, so again, the inferior glide is what kind of motion? Component motion. The inferior glide of the humeral head. It's a component motion that's necessary for coronal abduction. Also incorporate shoulder flexion as well, and scapulohumeral abduction as well. All right. There we go. I'm gonna start with assessing Tia's anterior glide of the humeral head on the glenoid cavity. Okay. And so I placed a little towel roll, I kind of flattened it, and placed an entire roll on the anterior aspect of her chest, right? So this is going to help to stabilize her acromion. I don't want it to move. The acromion is part of what? Scapula. Okay? So in a sense, I'm stabilizing. The scapula. But yeah, it's part of the shoulder joint. One of the I know where you're going, Sal. One of the joint complexes of the shoulder joint. Okay, so good. So now, I'm gonna come right here also. My stabilizing hand is gonna capture the posterior aspect of the scapula. And now, I'm gonna bring my thenar eminence and make sure that I'm not on the joint line. Lift up for me a little bit more. There we go, good. I just scoot the towel in just a little bit more to make sure it doesn't block the joint line. And now, my force is going to be anterior and medial. All right, anterior and medial. And so, want to make sure you block the scapula, right? And so I felt her scapula kind of move. That's when I added extra pressure to stabilize it. I'll bunch up her skin a little bit more. There we go. I felt like I was mobilizing skin. All right, good. So again, got the towel stabilizing the acromion and front aspect of the chest, and my hand right here just coming over. My stabilizing hand is across the top of the shoulder and the posterior aspect of the scapula. And again, my thenar eminence is mobilizing. Is on the posterior aspect of the humerus, proximal humerus, and I'm mobilizing anterior and medial. Something don't feel right to me. This side I felt a whole lot of resistance. Felt like I couldn't achieve the move how I wanted to. Okay. All right, able to get to where I want to go on that one. This one is making me work harder. This side right here, her anterior glide and prone on, what's this, the left shoulder joint complex? So her left anterior glide of the humeral head on the glenoid cavity, is the glide would be considered, I'm gonna say slight to considerable. I'm not definite with one of them yet, but slight to considerable hypomobility with the anterior glide of the humeral head in a prone position compared to this right side. All right. So good. I got in a loose pack position, right? So now I'm gonna assess the anterior glide with her in supine. So again, I'm gonna go ahead and use the wedge on this one to stabilize, to help me with stabilizing the scapula. And make sure your wedge is right up underneath the scapula, okay? So I'm gonna use the wedge for helping me with that, okay? And remember, my force is an anterior medial force. So I'm gonna come right here. I'm stabilizing the acromion right here. Coming right here. And so y'all may wanna come around and look. So my force anterior and medial. All right. So with this one, right, you can look and see, right? You see any abrupt stop, any jerkiness? So it's smooth. Smooth, we're able to get to the end range, normal firm end range, right? So that felt good. This is the right. All right, let's see what the left side feels like and looks like. Because we're using our vision too, right? So let's see. The last time, which side did I have a problem with? It was the left.
This side.
This side right here, so let's see. So, all in all, I was able to get to her end range. I felt like I had to work a little bit harder though. But I was able to get to her end range. It was still smooth, all right? It felt easier in the supine position, so it could just be positioning, but I did get her end range. She did wince a little bit, right, with that one. So that let me know something could be going on, but I'm just gonna notate that to the side. So in the supine position, I would actually give her a grade of normal when comparison in the supine position, okay? So the anterior glide is a component motion necessary for what? Shoulder joint external rotation, extension, what else? Yep, coronal abduction and horizontal abduction, okay? So when you go back and study, make sure you notate what these component motions are necessary for, what movements they're necessary for. Because on your practical, I'm gonna say assess a component motion necessary for shoulder flexion. I may even be so specific. Assess a component motion at the GH joint necessary for shoulder flexion. Assess a joint plate motion at the acromioclavicular joint necessary for overhead movement. Assess a component motion at whatever joint necessary for this. That's how it's gonna look, okay? And so you're gonna have to know what component motion to assess, or what joint plate motion to assess, okay? All right. All right, and now we got the posterior glide of the humeral head. So it's a component motion necessary for internal rotation, sagittal plane flexion, and also horizontal adduction, okay? So you can see any of those. I could say assess a component motion at the glenohumeral joint necessary for horizontal adduction, right? And if you don't know that, then you're gonna be at a loss right there at the practical. So you gotta start studying like now, very hard, or else you can have a tough time. I have her wedge. I got my handy dandy wedge, right? Stabilizing the scapula. Now, with my posterior glide, my thenar, hypothenar eminences are gonna be on the anterior aspect of the proximal humerus, near the humeral head, making sure I don't cloud the joint line or cover the joint line. And now my force, look at my forearm. My force is in the direction of my forearm is gonna be posterior lateral. And she's wincing with that. She got something going on over here.
I think it's the block.
You think, oh, it could be the block. The block is not that comfortable. Typically, I put a towel on the block to try to make it more comfortable sometimes. Let's see if that helps. Go ahead, lie back down. Did that help any? See, cause she's a thin body, so she can feel it. You see what I'm saying? All right, good. Let's go to, now, oh, stay like that, I'm sorry. So, again, I can come across the body. So that was on the same side. I can come across the body like so. And with her, I can likely use a smaller wedge because I have a smaller wedge in the clinic. I just don't have smaller wedges in here. I have a red smaller wedge. So depending on the person's body size, I can go smaller with my wedge with her because she's a smaller person, right? So again, I can come across the body and move in the posterior lateral, mobilize in the posterior lateral aspect. But the force is in line with my forearm, my direction of force. And then if I wanted to, I could take this arm right here and stabilize a little bit more if I wanted to make sure I was adding more stabilization while I'm moving. Okay. She's not wincing as much with the towel rope, with the towel on it. So now I'm gonna compare, right? All right, same side. Okay, nothing's stopping me. I'm getting to the end quite easily. It's nice and smooth. That's what I want. All right, I'm gonna come across the body, like so. Again, I'm always making sure I'm not blocking the joint line. You see my hand placement, my thin arm eminence. And now she's wincing with this one. But although she's wincing, I would grade those as normal. I didn't feel any marked differences. Nothing jumped out to me that I would notate and put an asterisk by, okay? So I would grade her posterior glides. When comparing both arms, I would say normal. Notice you all, Dr. McClure and I saw this during practicals. Every year we see this. So notice I'm making sure I place this wedge on her scapula, on the posterior aspect of her scapula. Sometimes we see students they place the wedge way down here. We see the wedge placed all different kind of places. So I just want to show you another way of performing the posterior glide of the humeral head. So I can do it on the same side. I can also come across the body as well. So I'm showing you the one at the bottom. The one at the bottom being on the same side with the wedge. With this one, I don't need the towel roll because I'm taking the patient's arm and putting it, in a sense, across her forearm across her chest like so. So look, I still got good body mechanics. I'm not too forward bent at the trunk, but now you see my line of force is wet, aligned with my forearm. And now I can come right here and use this hand to just palpate the joint line and apply a posterior force, a posterior and lateral force, okay? Okay, I'm gonna compare that. So there we go, good. Again, my hand is just palpating the joint line to feel it. Again, you see my arm? I was able to get more with this one, a little bit more. So I would consider one slightly hypomobile compared to this one with the posterior glide, with doing it that way. But this is another way you could do the posterior glide. I can also come across the body. So I'm just gonna move this right here. I can come right here, right? And I can come across the body and I can palpate the joint line along with blocking the scapula with my left hand as I impart the posterior glide. And she's still wincing, still feel the same thing. Come right here, place my hand on the scapula while my thumb is palpating the joint line. Yep, feel the same thing. She got a little bit more over here, so it's consistent, more mobility on that side. We're gonna go through some joint play motions. The first one is distraction of the scapula. Go ahead, turn your stomach for me. So now, let my patient know I'm gonna come up underneath, all right, with my left hand. So Liz, I'm gonna come up underneath you like so. And so what I want to do is I'm gonna bring her into some scapular retraction as I assess with distraction. So as I assess with distraction, I'm gonna get the lateral border of my my second phalanx up into the medial aspect of her scapula. And I'm gonna lift her shoulder like so. So basically I'm bringing her shoulder and scapula into retraction and some extension. And so I'm trying to get up, woo-wee, what's this? Okay, I see. All right. So now she got some funky going up in here, but I'm distracting. You see this? So what am I trying to do with distraction of the scapula? What am I trying to do? Who can tell me what I'm trying to do? So what is this articulation called? So if I'm distracting the scapula, what am I trying to do with the scapula? There you go. I'm trying to move it away from the rib cage. Okay? So I'm attempting to distract it. All right? So if you look at the picture, I have this person's, in that second picture at the bottom, I have the scapula distracted through the technique that I'm using that I just described. So it could be a challenging technique depending on your patient. I'm gonna go look at the other side. Bringing my stabilizing hand up underneath her, coming around the anterior aspect of her shoulder, and then I'm gonna lift it, move her shoulder joint complex posteriorly towards me. And so I can get more distraction in the medial, in the mid aspect, and I can get some inferior aspect too. Okay. Jess is going to use the lumbrical grip that Dr. McClure showed her and talked to her about to achieve this. You see that? That's beautiful distraction. Get a look at that. That's beautiful distraction of the scapula from the thoracic cage. Very beautiful. Relax. You want to make sure you place a barrier in between you and the patient. And so in this case, I'm going to use this pillow right here as and I'm going to use this to also mobilize her as well. So scoot to the edge for me a little bit. Okay, keep coming. There we go. All right, keep coming. There we go. So see how her shoulder is forward? So this pillow wedge is gonna help me. All right. and just relax your arm right here. There we go. So I'm coming in kind of diagonal my body. So I'm gonna diagonal my body so where my right side of my thorax or abdominal region pushes into her. She's tough to get a distraction on in a sideline position. Let's see something. Now I'm gonna have to use my hand, but I'm still gonna keep my barrier here. I got it. I'm in there. You feel that? I got up under there. I'm gonna just move it away. I'm moving it away, kind of playing around with it. You know, she made me work. There we go. You see that? Basically, I'm trying to get up under that medial border of the scapula, seeing if I can get up under there and getting it away from the thoracic area. Okay? Moving it away from the thorax. Turn on the other side. Let's see what you got. All right. Now this is why I keep my nails like the way I keep them. I'll be doing this with my patients now. And so I got to keep my nails very, very low. Because this would be very discomfortable to her if I had nails digging into her. Cause look, I'm trying to get up underneath there. I got it. I go. You see that? I'm up. I'm up under. She said it doesn't feel good. It typically doesn't until she gets to moving better. You know? Right there, right there. There we go. Got it.
You didn't walk out in a sleep.
So come right here. All right. So now I got the inferior angle of the scapula, almost like a lumbrical grip, and I got the superior angle of the scapula and the superior border of the scapula. So I do using my right hand to do caudal glide or caudal movement, which is necessary for scapular depression. Then I can do cephalic movement of the scapula. So caudal, cephalic, caudal, cephalic. Very simple. Same grip. I feel like the person, if I feel like the person is limited with upper rotation, then I can come right here and say, okay, I can perform upper rotation in this manner. So you see, I'm gonna use my body a little bit more. There we go. Upper rotation and then downward rotation. So this hand is moving like so, and this hand is moving that way. That's for downward rotation. And then upward rotation, the opposite. So this hand is coming around the medial inferior angle, medial border, inferior angle, and moving up this way, while this hand is taking and moving down like so.